So this presentation today is presenting the concept of blending somatic experiencing into the treatment of anorexia nervosa. So kind of looking at an alternative approach to treating these disorders and adding in a more body-based concept and approach to the treatment. A little bit about myself. I recently graduated from Northwestern University's master's program in December of last year, so fresh out of school. And I'm now working in private practice in Denver, Colorado. So it is bright and early here. It's 7 a.m. But then I thought back to my capstone where someone in our program was from Alaska and they had to do their capstone at like 5 in the morning. So I figured if they could do that, then this should be no problem. And the client population that I'm working with primarily is young adults with eating disorders and related conditions. And then I have future plans to go on to attend a doctoral program in counselor education and supervision, particularly educating and supervising clinicians that will be working with eating disorders in the future. Oh, and I'm a scuba diver, and I make this point because it will be relevant in the videos that I'll be showing during the presentation. They're all, they're like home videos, they'll be shaky, they'll be lots of fun, but I wanted to definitely like make that note so we didn't wonder where the heck that was coming from. And then I also kind of wanted to ask you guys what was bringing you to the presentation, and I didn't set up polls or anything, so you can kind of put this in the chat if I think that's still open, and just kind of put out what's bringing you, mental health professional, if you're a dietitian, a nurse, a student, kind of so I can get an idea of who is coming. Cool, so we got some students, therapists, clinicians, students, and therapists. Cool. And that brings me to my follow-up question, which is, do you work with eating disorders? And that could be yes, no, sometimes. You could be like, I don't know, maybe. What's an eating disorder? You can put anything in there. Cool. Nice. So we kind of got a wide range of people and backgrounds coming into this. So I will do quite a bit of background on anorexia and anorexia clients and what that population looks like. So we will get that foundation for those of you who haven't worked with eating disorders. And then kind of I'll talk a bit about the current recommended approach for this population and treatment. And why I think that there's some gaps in what we're doing right now. So the learning objectives for the presentation are, first, to identify gaps in leading treatment interventions for anorexia, clients who are undergoing weight restoration. 2, we're going to describe why somatic experiencing could be beneficial in the treatment of chronic and traumatic stress produced by weight restoration. So this will kind of be an original concept that I'll talk about, us beginning to conceptualize this actually as a traumatic stress response. And third, identify the 3 parts of somatic experiencing that could be used in the treatment of anorexia. So the presentation is going to be broken down into about 4 parts. It'll be like 45 minutes, and then we'll have plenty of time for some questions at the end. First, we'll look at who are we talking about. And in that section, I'm really going to introduce what anorexia is and who is affected, kind of break down maybe some stereotypes that we're coming into this with and preconceived notions about what that disorder looks like. And then we'll move into why do we care, which is really where we'll look at the dangers, complications, and risk factors for clients who are diagnosed with anorexia. We'll also look at the prevalence of the disorder and why mental health professionals, nurses, doctors, why we should all be invested in finding a treatment approach that's a little bit more effective. We'll talk about what needs to change. So we'll look at the current treatment breakdown that's most recommended for this population and fill in the gaps. Really like highlight what we might be missing and why relapse rates continue to be so high. And that moves us into how do we change things. So that's the meat of the presentation. And that's where we'll look at why somatic experiencing could be a viable alternative option for clients who are diagnosed with anorexia and how it might be implemented in actual sessions. So before we jump into things, I want to do a little exercise with everyone. You don't have to share anything. This is more like a personal exercise, but if you have pen and paper, kind of get that out. And I'm gonna ask you to really sit down and ask yourself, what are some of your biggest fears? And I say you don't have to share that because that is an extremely personal thing to ask of a group of strangers, but you can keep it like light, like maybe spiders, heights, tornadoes. I want you to write it down and have it handy so that we can really reference and ground ourselves to the root of this presentation, like how anorexia clients are feeling during the weight restoration process. So I'll give you a few minutes to do that, or seconds really, you don't need minutes. And then once you've come up with something, I want you to kind of like settle into that. And I want you to imagine that this fear, whatever it is, I'm going to use the fear of sharks. It will be relevant later on in some of these videos. So we're going to pretend that my fear is sharks. It's not, I actually love sharks, but for now, right now it is. And this fear of sharks overtakes my life. It takes me out of social relationships, prevents me from going to work, really turns me inward, starts to break down my body. I end up at a residential treatment facility for this fear of sharks. And I sit down in a room full of professionals. I've got my therapist, I got my dietitian, I've got my psychiatrist and my doctor. They're all like, we can help you. You've come to the right place. You just have to sit in a room full of hungry sharks for 30 days. And like, imagine what that would feel like. So maybe your fear was like spiders. Okay, hundreds of spiders. They've got to crawl all over you. But don't worry, we'll be here to support you. And that will be a huge indicator on whether or not you can sustain recovery down the road. Is your tolerance and acceptance of that reality. So this is kind of how I'm conceptualizing things are for anorexia clients who walk into a residential facility, and from day one, they're told, you've got to start the refeeding process. You got to start the weight restoration process. This is the only disorder where confronting a core diagnostic fear, so the fear of gaining weight, is actually part of the treatment process and a clear indicator on whether or not they're going to sustain recovery down the road. So they have to figure out how to be in that room of hungry sharks. So I want you to keep that close by to reference, because every time that I'm talking about weight restoration, weight gain, core diagnostic fear, for you, that core diagnostic fear is the fear you just wrote down. So you're kind of trying to connect with the narrative of the client that is going through this process. So we're going to start with the who are we talking about? We're talking about clients with anorexia nervosa. Now there's 3 distinct diagnostic features according to the DSM-5. The first is persistent energy intake restriction. And this could look like a lot of different things. I think the first thing that might pop into our head is food restriction. But it could also look like excessive exercise, purging, diet pills, laxative abuse, anything used to prevent the body from absorbing all the necessary nutrients it needs to sustain a normal and healthy body weight. The second is the intense fear of gaining weight or becoming fat. So rational or irrational, that doesn't really matter for the case of this presentation. It is that the anorexia clients, the idea of gaining weight or having their body change results in an extreme stress response. Fear elicits a threat. and a threat is found in our biological response to a situation. So it's not something that the clients can just talk themselves out of. We can't just sit here and be like, I know this is a distorted thought, and on and on and on. I mean, it feels in the body like this is something that I have to starve myself in order to feel okay. And so the whole body is essentially responding as if there is a threat. And then the disturbance in self-perceived weight or shape. So clients are unable to perceive themselves how others may see them. Even if a client is losing weight or someone is concerned, the client will not necessarily see any body changes. So this really perpetuates that self-starvation, and in the most extreme cases can lead to a client actually starving themselves to death. So I want to take another pause, and I want to make one thing really clear. Not all individuals with eating disorders are underweight. In fact, most individuals with eating disorders are not underweight. You're going to hear me talk a lot in this presentation about the weight restoration process, and I want to put it out there that I know this isn't a universal experience. And the weight restoration process for individuals struggling with eating disorders across the board will look different in individual. It doesn't necessarily mean like we have to gain X amount of pounds in this amount of time. And so just for the sake of this presentation though, the intervention of the weight restoration process that happens specific to anorexia clients is pretty significant. And I want to make it clear that I am aware that that's not a universal experience for everyone. And then one more thing to get really clear. So I think we've been told in our society and through media that anorexia looks like one thing, and it is an affluent, thin, white female who looks in a mirror and sees themselves different than they actually are, and it's like this really tragic, glamorous story, right? I'm not really talking about that. We never should have been talking about it like that. Anorexia actually looks a lot more like this. So it's people across all gender spectrums, men, women, tall, short, all different body types. Anyone of racial or ethnic backgrounds can be affected by this disorder. And as we break down apart that stereotype, there is more research going into parts of the world that we didn't previously associate with this disorder. And we are seeing that there is increased prevalence rates in those areas as well. We just kind of had to start the conversation. So there's some specific challenges that are specific to treating anorexia. So the energy restriction leads to a significantly low body weight. Now the term low body weight can be disputed. We could have a whole presentation on what that means in and of itself. And prior to the revisions of the DSM-5, the DSM-4 had individuals needed to be at the minimum or below a low body weight, so about 85% of the ideal body weight on growth charts, and about 18.5 BMI. But now the DSM-5 states that clients just have to fail to maintain a normal body weight in the context of age, developmental trajectory, sex, and physical health. So it's much more subjective to the individual that's walking into the room. So let's say a teenager who their entire life has been on the growth chart for weight about 99th percentile, and then at 14 drops to 90th percentile. Before our society wants to give her a pat on the back and tell her like, great job, first we need to notice that that's a significant weight drop for someone who their entire life has been on a certain trajectory. So that alone would be classifying as the failure to meet those basic nutritional needs. And then regardless of BMI, growth charts, and all this jargon, the energy restriction will lead the client to need to restore weight while in treatment. There will be individuals that will be on an actual weight restoration meal plan, so an excess of calories, having to meet certain weight goals. and which means they're medically or clinically underweight. And then there will be those who need to restore weight simply because their bodies have been starved for so long, and this will happen without an excess of calories. So they could be in the normal weight range, but we need to restore them to at least intaking the proper amount of nutrition, and inevitably the body's going to change. The body is getting a different amount than it was prior. This is where it gets really tricky and messy and sticky, because a core diagnostic feature of anorexia is the fear of gaining weight or becoming fat. So recovery requires them to gain weight. So it's the only disorder where confronting a core fear is a clear indicator on whether or not a client will sustain recovery. Whether or not you can deal with sitting in the room full of hungry sharks. And there's a lot of research even to back that getting to about 95% of an ideal body weight, it is a strong predictor on someone being able to sustain recovery long term. Once we're able to get to about 95%, the fear of gaining weight, the fear of the body changing, those will start to fall away a little bit. And so, but that doesn't negate the whole process of leading up to it, that we are in an intense, like, traumatic stress response in the idea of even having to embody a changing body. Also, clients with anorexia show a huge ambivalence towards recovery in the first place. I mean, we could talk about the pats on the back that we get, the societal acceptance, the kind of healthy eating movement. There's a lot of ways that clients can kind of fall through the cracks and be societally accepted by their disorder. Also, the restriction works. It takes away anxiety, it takes away depression, it removes us from life. And so the mix of kind of the pride that can come with being small and shrinking away, and that achievement, alongside the fact that this is working, there's a huge ambivalence in clients to even like want to recover in the first place. And this is also kind of like a significant point, because that is why a lot of times these clients end up in residential levels of care. There's this ambivalence for so long. There's so many pats on the back. There's so much, oh, you're doing so great, until we're at a certain point, and then we kind of need the 24-hour level of care. So that brings us to, why should we care? So that is kind of the conversation for complications that are associated with anorexia. It's one of the deadliest psychiatric disorders. I say one of because opioid use disorder is right up there with it now, especially with the pandemic and the year that we've had. But still, the standard mortality rates for these disorders, it's a huge range. It's really hard to pin down because of all of the misconceptions on what these disorders look like. People might come in and pass away from things that are written down not as anorexia, but let's say like cardiac failure. It's really hard to know what the numbers are exactly, but I've done enough digging, and I think like this is about where we're at. There's a standard mortality rate between 0.7 and 12.8. That's a huge range. But what I've come to understand is that the mortality rate increases each decade that you have the disorder. So we're talking about people being diagnosed really in early adolescence typically, or at least showing symptoms during early adolescence, even if they aren't diagnosed. So if someone started restricting their food at 12, and then at 22, we're looking at getting treatment, that's 10 years that have passed. So that 5% mortality rate that they were confronted with at 12 is 10% now at 22. Then they're 32, we're at 15%. And so each decade that this disorder goes on, that mortality rate drastically increases. And then the suicide risk is 200 times greater in this population than the general population. Not to mention the medical complications. When you're starving yourself, it affects every system in the body. It can affect heart, lungs, kidneys. electrolyte imbalances, osteopenia, stunted growth, hair loss, you name it. Anything is basically fair game. And there's a really poor prognosis for this population, even after receiving intensive care. So even after going through the residential levels of care to PHP to IOP to outpatient, the recovery or the relapse rates, and I looked at many different studies, many different lit reviews, we're looking at between 30 and 70%. So that's a huge range. And I mean, if we're talking on the 70% side, that's like 7 out of 10 people who have already received the care are going to relapse. And then only 46% of people fully recover from this disorder. That's less than half. And that is, once again, with targeted interventions. 33% will partially recover. So they might be able to sustain a normal body weight, but still hold on to the thoughts, beliefs, and anxieties around food. And then 20% will remain acutely ill, in and out of the system, inpatient care, medical complications, never so fully being able to surrender the disorder. The prevalence of anorexia across the lifetime is between 1.2 and 2.2%. That's in 2017. I think that those numbers are going to change. There's a lot of different research studies that are looking into Asian and Arabic communities, minority communities, trying to get more males to begin to speak out and talk about whether they are affected or not. It's estimated that about 25% of the population that struggles with anorexia is actually male, which, you know, talking 10 years ago, we would not put numbers that high. So I really believe that new research may uncover higher incident rates. Right now, it's kind of like said that the population of anorexia within like the US and Europe is stable, that we're not seeing an increase, we're not seeing a decrease, we're about the 1.2 to 2.2%. But that's not including, that's not targeting typically silenced communities or communities that we haven't been able to go and reach and talk to. So that brings us to what needs to change. So this is the current recommended treatment approach for individuals that are undergoing treatment for anorexia. So I made a point earlier to talk about how this disorder is not one that's easily given up. It's not one that someone's going to walk in and be like, this definitely isn't working. I definitely want to give it up. There is a huge amount of ambivalence. One, the fear of gaining weight. So being told like, hey, you need to restore weight, it's kind of like, peace out, I don't want to do that. And then also just the societal acceptance, and then it does work. It works to silence the anxiety. It works to silence the underlying like emotional repercussions that would happen when we release from the behaviors that we're using. So that's why typically individuals will end up in a residential level of care. So the disorder has progressed enough to where 24-hour non-hospital based treatment is kind of the best option. And then when you start looking at the way that residential treatment is broken down, I kind of see it as two branches. We've got the mind on one side and we've got the body on the other. And on the mind side, we're getting individual and group counseling, individual multiple times a week, group counseling every single day. And the theoretical orientation and interventions are coming from cognitive behavioral therapy or enhanced cognitive behavioral therapy, which is targeting eating disorder pathology, things like beliefs, and distorted thoughts around food, body, things of that nature. And then on the other side, we have the body and the medical and behavioral stabilization. And this is where the weight restoration kind of falls. It's in this category. And at a residential level of care, this happens insanely fast. We're talking like, you know, an average of 3 pounds a week, an excess of 35 to 4,500 calories. Like this happens really rapidly, primarily because of the cost of residential care. It's $1,000 a day. And even when we are talking about insurance covering that treatment, no, we still have to meet the deductible before you even admit. So that can be thousands of dollars. The out-of-pocket max will be met in the first probably 2 to 3 weeks that you're there. And then there's out-of-network costs. And so the bills just keep coming and coming, even if we hear the words, you're covered by insurance. And then insurance could just up and cut whenever. And so, you know, the team is really trying to get as much weight on these people before they discharge as possible, which in and of itself is a really controversial concept or topic. So the gaps in this current treatment approach. So CBTE emphasizes the cognitive processes that coincide with eating disorder pathology. So thoughts and beliefs around shape, body, food. However, this intervention has not proven superior over other psychotherapy methods in preventing relapse down the road. We can look at studies and we can see between admission and discharge that there's some improvement. We could also look at why improvement might be happening. The clients have to. You have to meet these certain goals in order for insurance to keep covering you. This is also the curriculum, for lack of a better word, that's like prescribed to you each day, the groups that you're expected to go to. And so of course there would be some sort of change. I mean, we're beginning to target some pathology. We're beginning to get nutrition back into us. But then when you look at studies and you look like 3 months, 6 months down the road, CBTE alongside psychodynamic therapy or mindfulness-based or any of these other types of therapy does not prove superior. We don't see a remarkable long-term sustainable improvement. And then there's my theory is that the lack of long-term benefits might be due to CBTE's failure to address the individual's present emotional and physiological states that are happening during the weight restoration process in particular. So clients who are undergoing weight restoration are experiencing significant biological changes. Weight restoration is a necessary component for individuals' recovery. In fact, having clients restore to about 95% of their ideal body weight is a strong predictor in sustaining recovery in the long term. However, it's a really intense process. Like I said, you're gaining an average of 3 pounds a week. So 3 times 4, that's 12 pounds a month. You're eating in excess of 35 to 4,500 calories a day. It's a lot of food for someone who has been restricting their intake prior to this, probably for months, maybe even years. And happens really quick to mitigate the cost. And also there's this controversy on whether getting someone restored, essentially catapulted into their healthy body is the best approach, or whether this should be a more slow and gradual process that takes place over time. So that's kind of like its own conversation in and of itself. And none of these interventions are then processing the body's reaction to the weight restoration process. We're targeting the mind and the thoughts and the beliefs, but the body is changing, and there's a lot of fear tied up in the body. And so I think really redirecting our attention inward would help fill in some of these gaps. So that's why somatic experiencing might be able to help. So it integrates body awareness directly into the therapeutic process. SE states that unconscious emotional processes and conscious thoughts are reciprocally influencing one another, meaning that emotional states cannot influence our physical states, and the mind cannot be addressed without attention on the body. So that little chart that I put down, and where there's 2 branches, we're looking at mind and body. Those really should be mind and body. there should be some kind of communication happening between the two. The two should be linked from the beginning of the treatment process. So, yeah, so CBTE is failing to link the conscious thoughts with the body's unconscious processing of their physiological state, which in the case of the anorexia client in treatment is the stressful experience of weight restoration. SE would be able to direct the attention to linking the body's experience to the mental state that the client is in. Awesome, but what is somatic experiencing? I feel like I've been doing a deep dive into this for months, and I still come up with a lot of like woo-woo language, like energy, body, you know, connection. So I'm gonna like do my best to try and make this really scientific and like pare it down. So somatic experiencing is a novel form of therapy developed by Peter Levine, and really over the last 45 years. And it focuses on resolving the symptoms of chronic stress and post-traumatic stress. SE differs from cognitive therapies because that its major interventional strategy involves bottom-up processing, not top-down. So we're directing the client's attention into internal sensations rather than primarily cognitive or emotional experiences. SE is not a form of exposure therapy. It specifically avoids direct and intense evocation of traumatic memories. Instead, it approaches those charged memories very gradually, creating a new corrective experience that actually physically contradicts the feelings of overwhelm and helplessness that were previously associated with those memories. So now this is where my scuba videos get to come into place. I have two videos to show you. They're metaphors for how to illustrate the goal of somatic experiencing in therapy. The first depicts how trauma can overtake our lives. In the first video, you're going to see a feeding frenzy of black-tipped sharks. So maybe sharks are also one of your big fears. So this will be great. You'll be right in that room that we're talking about with clients. And when we're unable to discharge our biological reaction to a traumatic experience, so when we're completely surrounded and overwhelmed, that reaction gets trapped in our nervous system, creating many traumatic symptoms that interfere with our lives. And this can lead us to feeling like we're essentially surrounded by hungry sharks. So now in the second video, we have one single shark swimming alone in the distance. And we have this great moment at the end where you see my dad out next to the shark giving it the thumbs up. That's the client being like, yeah, I can handle this. I can handle this single shark, you know? And the way I'm thinking about it is that somatic experiencing takes trauma in pieces. We gradually and slowly process our body's reaction to different experiences. Through SE, we would be able to find the resiliency to look at a single shark, which is far more manageable for our mind and body to process than that swarm of hungry sharks. So this brings me to my next proposed way of conceptualizing the weight restoration process for anorexia clients, and that is as a traumatic experience. According to somatic experiencing theory and the way that it defines trauma, this works. As he states that trauma lies in the body through an overwhelmed nervous system, we understand that a key diagnostic criteria for anorexia is an intense fear of gaining weight or becoming fat. So it would be safe to say that anorexia clients interpret weight gain as a threat. And yet weight gain is a necessary component of their medical stabilization. As clients are weight restored, they are constantly and consistently exposed to this core fear. When we're exposed to our fears, our nervous systems become activated. You might have watched the video with the sharks and felt like a little tense. Maybe the breathing felt a little too Darth Vader for you. You know, like that can be really stressful. We start to notice the pounding heart. Maybe you're sweating. I believe that the ongoing exposure without processing this activation leads to a dysregulated nervous system, leading me to interpret the weight restoration process as a traumatic experience for anorexia clients. And then when a client comes to discharge from a residential level of care, they're left with this overwhelming experience of their body's changes, having never properly addressed it while in treatment or in therapy. And research has shown us that another indicator of relapse in this population is bodily distress. So essentially, by not addressing weight restoration in the treatment process, we're not properly setting up these clients for sustainable recovery down the road. We're kind of just throwing them to the sharks. This is where we talk about tonic immobility. So tonic immobility is a natural state of paralysis that we see in wild animals. And wild animals are able to enter and exit this freely. It may be a way of avoiding or deterring predators. So when there is like a threat that we see that we cannot escape, we essentially play dead. And then if we get out of that response, these wild animals are able to kind of discharge the anxiety and the trauma that was pent up in their body, shake it all out, and return to their normal way of functioning. Domestic animals cannot do this and resemble humans in their response to trauma. And when animals experience fear or are frightened, they go into freeze. And when it takes longer and longer, it takes longer for them to come out of that tonic immobility. And if they don't come out of the tonic immobility, they collapse and it becomes a learned helplessness. I've been in this situation for so long, I've been confronted it for so long, and I know that I can't escape it. And so I just have to surrender to defeat. So defeat, submission, shut down. Attributing the process of weight restoration to a traumatic experience would mean that we also have to see the failure to discharge and acknowledge the stressful embodiment that the clients are going through as they continually have to face this fear, as over time being translated into a learned helplessness. We can't escape it, so we'll just surrender defeat, especially while we're in that residential level of care. That is your option. Your treatment plan says that you have to gain X amount of weight, you have to be compliant, you have to meet these goals or else insurance will cut, or you'll be deemed non-compliant. So in that microcosm, that is your only option. So we surrender to it. We surrender to the defeat. But SE states that the trauma response is still caught in the body and in the nervous system, and will later cause symptoms such as panic, anxiety, depression, hopelessness, or in the case of an anorexia client, having discharged from treatment, body hatred, body dissociation, low tolerance of physical sensations, return to symptoms, relapse, repeat the process. So how do we change things? How would somatic experiencing look like with anorexia clients? It's a really good question. There are very few research studies on somatic experiencing, and none of the ones on somatic experiencing are with anorexia clients. The handful of studies that have looked at SE are all for PTSD, and they show remarkable improvement, a lot of promise, but there does need to be further research looking at anorexia clients undergoing somatic experiencing treatment to really, before I can state like, this is exactly how successful it would be, this is exactly what it would look like. But I am going to propose some ideas on how this may overlap with anorexia pathology. So the goal of somatic experiencing when treating anorexia would be to discharge the stressful response related to weight gain while they're actively undergoing the restoration process. When utilizing somatic experiencing in therapy sessions, 3 key elements would need to be put into place to help guide the body's nervous system back towards a balanced state. And these elements would include resourcing, pendulation, and titration. So first talking about resourcing. Resourcing in somatic experiencing happens at the beginning of treatment. And it's the process of supporting the client in establishing a sense of safety and comfort. Resourcing allows the patient to establish positive feelings from which the client will then be able to pendulate into distressing sensations and back out of later on in treatment. When working with anorexia clients, it would be essential to invite the mind and body to attune to sensations that are safe, comforting, and good, so that when stress is high, they can return to the resilient states. And now when I think about actually doing this with an anorexia client and having someone sit down, with really any eating disorder, but particularly we're talking about anorexia, and being like, okay, so settle in, let's look internally, let's feel our body. You're gonna be met with a huge amount of resistance. No, I hate my body. I don't wanna be in my body. I don't wanna think about my body. I hate every sensation that's coming up. And so when I start to think about actually making this work for this population, I say starting with something really simple. Don't go necessarily like, let's find something pleasant inside of us. Let's find something pleasant around us. Let's hold the fuzzy pillow that's on your counselor's couch. Let's notice the cushion beneath our seat. Let's just take those, and that one positive association can be enough to have a positive association to come back to later on once we dip into the distressing sensations. And that brings us to pendulation. So pendulation involves supporting the client while pulsating between leaning into the distress and then leaning back into the resource state. So like thinking tap in, tap out, tap in, tap out. And pendulation utilizes the resource state by building the confidence in the client's ability to touch on distressing situations without becoming completely overwhelmed. The process ultimately helps create a resilient nervous system where the client can move back and forth between activation and rest without becoming stuck in either extreme. Pendulation in session with an anorexia client might look like leaning into the sensations arising from the restoration process and then returning to the previously established resource state, comfort of the couch cushion. For example, it might be really typical for the abdomen region to become bloated and distended during rapid weight gain. This can lead to a really negative association, negative self-perception. So SE would work to bring the patient's awareness to the abdomen region so that they can notice the sensations arising, bloating, upset stomach, discomfort. And this part would be really, really key to stay out of the thoughts and the beliefs. It's not, let's go and notice our abdomen region and tear ourselves apart about how fat we are, how uncomfortable we are, how we just need to go run and do whatever behavior to make sure that we can escape this. It's getting underneath that and getting down to what does it feel like? What does it feel like to be in that? Bloating, upset stomach, distress, or discomfort. So after noticing the distressing sensations, the patient would then be guided their attention to the previously noted comfort of the office chair. We're in it, we feel it, it's overwhelming, we come out of it. And then the last part, titration. Titration is the opposite of the body's natural reaction to trauma. Typically, a stressful experience will lead to an immediate and full activation of the nervous system. However, SE, titration is used to help slow down that process so that the client can process it in small pieces at a time. We move from the hungry swarm of sharks. And in the confines of like a therapy office, we would be able to just pull out a single shark. We're just going to look at one. We're going to deal with one at a time until we've looked at all of them. And then we've built a new association with how we can handle this distress. So the slow and continuous process of touching the activating experience and then returning to a resource state prevents the nervous system from becoming overloaded and landing in tonic immobility, the learned helplessness that we talked about. Continuing from the previous example, so an anorexia client undergoing somatic experiencing, we would establish the association with the comfort of the office chair, so that would be resourcing. And then after manifesting that positive experience, the client can move back and forth between the distressing sensation of the abdomen region, back to the chair, abdomen region, back to the chair. And then the patient begins titration, which is the process of knowing when to pause and take a step back from the distress and move our attention elsewhere. This could look like returning to the resourcing and, finding more resilient and positive associations that we could pull from in later sessions. So it's kind of having that discernment on when we've had enough. So no surprise, I have 3 more videos. They're all scuba diving, and they're all metaphors for what this might look like what it's a metaphor for how to conceptualize these 3 different parts. And the first one is of a coral reef. Resourcing can look like noticing the coral of the reef, the way it's moving and swaying, really taking in that experience before moving our attention to maybe some of the larger mammals that are swimming around us. So the second video depicts pendulation, and I want you to watch really carefully because this sea turtle at the beginning comes up and hits me on the head, and the sea turtle is the trauma. So we allow that trauma to just come, knock us on the head, and then swim away. And then we can redirect our attention back to the coral and some of the other things that are happening around us. And then this last video depicts titration. So it's a video of me surfacing after a dive. Titration is knowing when to get out of the water and when to get back on the boat and recalibrate before returning back into the ocean. So that kind of brings us to the end of our presentation where we talk about what needs to happen now. And that really means we need a call for further research. We need to be invested in finding alternative options for treating not only anorexia, but other eating disorders as well. So that starts first with some research to back it. And why this research is important. We talked about the severity of the disorders and the poor prognosis. So that in and of itself kind of speaks volumes to that there are some gaps in the way that we're approaching things right now. If only less than half of people who are undergoing intensive treatment are finding full recovery, I believe that there's got to be other things that we can implement that would help increase those numbers. And then also accessibility, cost, and increased resources. The current breakdown, residential care is not accessible to most people. It's insanely expensive. It involves taking time off work. These facilities are placed in neighborhoods and in areas that are not accessible to minority groups. And so thinking about giving us other options that might even be more effective that can happen at an outpatient level of care, that clinicians that are at community-based treatment or community centers can be then trained in somatic experiencing. They would be able to give these resources out for free. So this really begins to touch and be able to touch a larger range of communities that could be struggling with this. And also somatic experiencing could be a more individual approach. And so we can go at the individual's pace and what they need in terms of their own weight restoration process or whatever. So that brings me to the end. We've got an insane amount of sources. But yeah, I think we have maybe like 5 minutes if someone does have a question that they want to ask. Probably have time for 1 or 2. And if there's no questions, that's fine too.
Yeah, I guess I had a question. I was just wondering if you can give like an example of like something like if I know you gave a lot of examples like during your talk about what that looks like. Have you ever like used this specifically like in your sessions as a counselor? Like what does that look like? Or even if it's not like with an eating disorder client, have you ever like used this? You know, I'm sure you have used it, but what does it look like, I guess?
Yeah, I mean, I think like clinicians or like therapists will find that when you start to orient to this idea of bottom-up processing or like getting in touch with internal sensations in the body, it comes up all the time. And just knowing like a handful of ways to approach situations like that can already, you're going to be able to start seeing it trickle into like a lot of different sessions. I did have a client like a couple over the winter who developed this really intense fear of driving in the snow. She had never had this happen before. We originally were working on body image, and then she comes in one week and she's like, I had the strangest experience where I was driving in the snow and I'm driving and my arms completely went numb. My whole body shut down. I couldn't even feel, like I had to pull over, have someone pick me up. And she's like, I don't think I'm ever going to be able to drive in the snow again. Because if that happens again, like I will not be able to get through that. And so we kind of like sat down in session and, you know, closed our eyes, oriented to that spot, and went through the entire situation. What did it feel like to have your arms go numb? What do you wish you could have done? What resources could you have pulled on in that moment that could have helped you get through it and brought you back to full control of your body in such a stressful time? And she talked about then a couple weeks later, she was like driving in the snow and driving. She's like, I thought about all the things that like we were talking about, and I was like hitting my arms to wake them back up and shaking out my discharged trauma, like discharging the trauma, and basically like just telling myself that I know that I can do this. And she did end up like getting through. She got home in the midst of a snowstorm, and since then the anxiety and the panic has not happened in those situations. There might be like some residual like anxiety of like association with what's happened in the past, but every time I ask her, I'm like, it snowed last week, how did it go? She's like, oh no, I know I can handle it now. And so I thought that was like probably like too much of a wrap it up in a bow type situation, but it is kind of a cool one that I just worked on it like in the last couple of months. So.
Cool, thank you.
Yeah. Well, if there's no other questions, I think that we only have like 2 minutes left. So I don't know if Andrea, like if we just end early or what, but
yeah, that's fine. I just want to say thank you so much for this presentation. It was so much value. I think we can all agree, yes, with the spare fingers, Sarah. Yes, Eric. We can all agree that it was so much value that you presented here, the videos, and just being able to help us conceptualize, anorexia so much better and just eating disorders. So thank you so much, everyone. You are free to go to your next sessions. Enjoy and welcome to the virtual conference.